Hello and welcome fellow YouTuber. The purpose of this video is to provide an overview on identifying, maintaining, implementing, and monitoring of midlines. This will be done by reviewing the current research, Infusion Nurse Society guidelines, current hospital policy, and the midline itself. So without further delay, let's get started. So what is a midline, you may ask? Well, a midline will be defined for this video and at our facility as a peripherally, not a central, venous access device that is only inserted in the arms to obtain and maintain longer and more reliable access for intravenous treatment lasting less than 30 days. A midline does not mean that it will go to the midline anatomically. It is the middle ground between a normal peripheral line as shown here. Here you can see from left to right a systemic increase in size from a 24, 22, 20, and 18, a single lumen midline, a PICC line, and then a dual lumen midline, and then finally a 16 gauge needle. The midlines at our facility are either a 10 centimeter 18 gauge midline or a 5 French dual lumen midline. There are variations in length and size, but we only use these two products at our facility. You can tell that the single lumen midline is an 18 gauge by the color. Note that both the 18 gauge needle and the 10 centimeter 18 gauge midline have green hubs. The dual lumen is a white line and is a 5 French, just like the PICC line. Additionally, it's worth noting that if you are placing a 16 gauge needle, you are effectively placing a line larger than a central line. You may wonder how that is possible, and the answer is the tip location. A central line will have its tip in the superior vena cava portion of the body, as shown here. For the purposes of this video and our hospital policy, a midline goes in the arms, but the tip does not cross the axillary vein into the subclavian vessel or does not pass the head of the humerus, as shown here. Again, a common misconception is that midline is referring to anatomical position. This photo is demonstrating what midline means anatomically now. So if I were to say I was going to place a midline, then I'm talking about placing the vascular device. However, if I was to say I'm going to place a line at the midline, then I am actually saying I will place a central line. To clarify what peripheral means, we are talking about the arms and legs of the body. However, as stated previously, we do not place this line in the legs and only in the arms at our facility. So you may be asking now, what's the difference between a PICC and a midline? The answer is where the end or tip of the line is located. The PICC line's tip is located in the superior vena cava, making it a central line. A midline's tip does not cross past the shoulder and as such is not considered a central line but instead a peripheral line. It is extremely important to remember this as it will help you define lines in the future. So let's continue now to how to physically identify midlines now that we have a brief understanding of what a midline is. Here we have the actual physical single lumen 10 centimeter 18 gauge midline to look at that is used at our facility. You will note that it says it is 10 centimeters, therefore it couldn't possibly be a central line if inserted in the arm. The 7 milliliters per second max refers to this device being a power injectable device for radiological imaging. This particular device is a barred power glide. You can see that the tip of this particular midline has a purple color, and that section represents reinforcement to allow for improved and maintained aspiration flow. Additionally, it prevents catheter collapse during aspiration. In this section of the video, you can see how a midline dressing should look. It should always be clean, dry, and intact. It should have a stat lock on it. There should either be a bile patch, Gardava, or chlorhexidine gluconate gel patch on it, and you need to be sure to change it every 7 days. So why would I need a midline, you might ask? If the patient has a need for IV treatment under 30 days, then a midline is indicated. If the patient has need for partial parenteral nutrition, then a midline is appropriate. If there has been more than 3 failed IV sticks, then a midline is warranted. Palliative or hospice care is also an indication. Some consider temporary administration of a single vasopressor up to 48 hours controversial, but we are going to show that this is evidence-based. This is the actual protocol for vasopressor administration through midlines developed and published by North Shore Long Island Jewish Medical Center in 2015. Our protocol reads the following and is based off of this published study. Administration of vasopressor therapy through midlines can safely occur at our facility, but there are rules to this practice and are as follows. The decision to use vasopressors must be assessed and approved by a physician. Volume status of the patient must be evaluated via ultrasound technique or clinical assessment prior to peripheral vein administration of vasopressors. Patients must have a clinical indication for the use of vasopressor therapy. Peripheral venous vasopressor use is indicated for a maximum of 48 hours. However, therapy may be extended under the discretion of a physician. Peripheral venous access may be used for only one vasopressor. If multiple vasopressors are required, a central line is warranted. Access insertion point and hardware. Midline catheters cannot be placed in the antecubital region, hand, wrist, lower leg, or foot. Midline catheters must be placed in the forearm, upper arm. Insertion must be contralateral to the blood pressure cuff. Intravenous catheters must be at least 20 gauge or larger and inserted or verified with ultrasound guidance. There must be blood returned from the IV catheter prior to vasopressor administration. The IV site must be assessed every 2 hours while vasopressors are infusing and site assessment performed and documented. We have been using this protocol for nearly 3 years now without any issue. So who decides when a midline is needed? Traditionally, a medical doctor, physician assistant, or a nurse practitioner can decide to order a line after assessment and diagnosis has been determined. However, you may act as an advocate for your patient or even yourself and appeal to the attending medical doctor, physician assistant, or nurse practitioner and explain the rationale for midline placement. If your rationale makes sense and there is no contraindications, the line will most likely be ordered. So now you may be asking who can insert midlines. Traditionally, a registered nurse will come to insert these lines. However, respiratory therapists can also insert them. Doctors, physician assistants, and nurse practitioners do not usually learn to insert this line, and unfortunately, only registered nurses are inserting these lines at our facility currently. So let's now discuss where the midline is inserted. Generally speaking, the midline will go between the elbow and the shoulder, specifically in either the basilic, cephalic, or brachial veins, but could also be placed on the forearm in rare instances. This photo shows the approximated location and name of each of these vessels in anatomic position. So what are the risks? Before we answer this, you should know that these are common listed risks, and they are more of a formality than anything. In other words, they don't necessarily all apply to a midline insertion. So let's review each of them systematically. Pain or discomfort at the site of insertion. For a midline, we do not use lidocaine at our facility, so while it will hurt, it is not going to hurt as much as it would if you had been stuck in your hand. The hand is responsible for fine motor skills, and an example of that is someone playing the piano. There is precise and quick movement occurring with lots of stimulation to and from the brain. Due to this, pain sensation is increased when there is trauma or damage to the hand. Now compare that to the upper arm that simply just goes back and forth. It does not require as much nerve innervation to have this simple movement occur, and as such, the location of the midline in the upper arm will traditionally hurt less. Puncture of the blood vessel causing bleeding at the site of insertion. This is the name of the game. You're going to have a line inserted into your blood vessel, so there is going to be blood. That lets us know that we are in the right spot as well. So this is an expected complication or risk. Phlebitis or infection of the vein can occur due to foreign bacteria entering into the vessels. Traditionally, it causes a red streak to go up the arm. However, this is usually associated with line contamination during line insertion and rarely happens with midlines. Another risk is infection at the site of the catheter insertion, blood vessel, or other body organs such as the heart or brain. All indwelling devices have this risk, but when there are signs of infection, the healthcare team will assess the location and determine if the line should be removed. In the case of midlines, there is rarely infections at our facility. Most infections have to do with issues with maintenance practices at the bedside or at home when a patient manages their lines by themselves. All lines will be primed before they are used with saline and purged of bubbles prior to hooking up to the midline. This prevents air embolism, and it is a rare occurrence. I have never actually seen or heard of this taking place with a midline. This is more of an issue with central line placement when inserted into the neck. Nerve or tendon injury or irritation can occur, but since this is an ultrasound guided line placement, the nerves, arteries, and veins will be identified before an attempt will be made to insert the midline. As such, it will be unlikely that a needle would hit a tendon or nerve. Since we are only sticking in the arm, there is no way that a 10 centimeter midline could travel to the lung and harm it, causing a pneumothorax. This is more of a complication of subclavian central line placement. If a line was inserted centrally and it entered into the heart, it could tickle the heart and cause it to beat out of synchronization with the body. We would simply need to pull the line back if this occurred. However, with a midline, the line does not cross into the central circulation, and this risk does not occur. We would only be able to know if you had an allergy to the material of the midline if we actually placed it. I have not actually seen this occur or heard of this occurring at our facility in at least 10 years. However, anyone who receives X-ray contrast should increase their fluid intake in order to rid their body of said material. This is not specific to the midline, but instead their radiological test using the contrast medium. The line could be pulled out on accident, and that would simply mean that you would have to have it replaced. We do not suture these lines, but instead apply an adhesive to them so that they will adhere to your skin. Breaking off of the catheter into the bloodstream would be extremely difficult to occur unless someone was trying to cut the line for some bizarre reason. There's no clinical reason for the line to be cut while still inserted in the body, and doing so would be reckless. Therefore, it is extremely unlikely that a proceduralist would do this. So when can midlines be inserted? After the midline has been ordered, the proceduralist will be reviewing your medical and surgical history, documentation of chronic kidney disease, recent chest trauma, dialysis, shoulder surgery, sepsis, arm infections, or recent pacemaker placement will require further investigation or clarification before insertion. Additionally, the indication will need to be valid before the proceduralist proceeds. If they find an issue, they may not perform the procedure at all. So what are the contraindications for placement? Here's a list of reasons why we may not place a midline. There's a patient history of thrombosis, hypercoagulability, decreased venous flow to the extremities, or end-stage renal disease requiring vein preservation in accordance with INS standards of practice. For renal or dialysis patients, an order must be obtained from a nephrologist to use this product. TPN, or total parenteral nutrition, through a midline is contraindicated. To infuse more than one vasopressor through a midline is contraindicated. To infuse a single vasopressor without the ability to draw blood through the midline with a 3 ml syringe is contraindicated. Placing a midline on the same side as a mastectomy, arm injury, or arm infection is contraindicated. If the patient's body size is insufficient to accommodate the size of the implanted device, a midline is contraindicated. If the patient is known or suspected to be allergic to materials contained in the device, the midline is contraindicated. Local tissue factors and/or past treatment that will prevent proper device stabilization and/or access are contraindicated. Examples might include recent shoulder surgery or recent pacemaker placement. So what are the benefits, you may ask? Well, blood can be drawn from a midline, reducing the need for needle sticks. Midlines can last up to 30 days and generally longer than the duration of treatment that is needed so that you don't have to have IVs restarted constantly. Patients can be discharged sooner with the midline so that they can continue their treatment outside of the hospital and save money. Overall, the process of having a midline is less painful than having a traditional IV inserted, and most patients report that midlines provide a higher quality of care for their treatment. How will the proceduralist know that a line is needed? At our facility, when a midline is ordered on the computer, a slip will print out in the house supervisor's office. They will notify the entire vascular team of the need for a line. At that time, the assigned vascular access team member will make contact with that department and interview the staff on the medical and surgical history of that patient and the indication for the line, at which point they will decide how to proceed. This section of the video will have to do with the maintenance of a midline and how to do so. In terms of flushing, midline catheters are to be flushed with a pulsatile technique before and after each use and every 12 hours when not in use with 10 milliliters of NS and at most a 10 milliliter syringe. Midline catheters may be used for lab sampling in accordance with manufacturer indications and guidelines. So prior to sampling, flush the line with at least 10 milliliters of normal saline to assure patency. You would then clamp the extension set. Then remove the cap from the hub of the extension set and scrub the hub with chlorhexidine or an alcohol-impregnated swab. Using a 10 milliliter or smaller syringe, slowly pull at least 5 milliliters of waste from the catheter and discard. Using a 10 milliliter or smaller syringe, slowly pull enough blood for the required lab sample. Clamp the extension set and then remove the sample. Attach another 10 milliliter saline flush, then unclamp the extension set and flush with at least 10 milliliters of normal saline in at least a 10 milliliter syringe in a pulsatile technique. At that point, you would then replace the cap. If you are having difficulty with lab draws, you need to aspirate with a 3 milliliter syringe. While a 10 milliliter syringe creates little PSI going forward, it creates a tremendous amount when you pull back, and the opposite is true of the 3 milliliter syringe. This will help keep the line patent for blood draws. Additionally, place a tourniquet on the arm 6 inches above the insertion site to allow for venous pooling, which will help tremendously. This isn't a central line. You have to treat blood draws like any other peripheral lab draw and use the tourniquet. Additionally, adding heat to the arm can help cause vasodilation and help with venous pooling. Dressings are to be changed every 7 days and as necessary when wet, loose, or soiled, utilizing a standard central line dressing kit. This is because the size of the device is larger than a traditional IV and requires a larger dressing. Using clean technique, remove the occlusive dressing. Using aseptic technique, don sterile gloves and remove the disc or gel patch, and after swabbing with alcohol at the wings, remove the stat lock device. Cleanse the site with chlorhexidine impregnated swabs and let dry. Use skin prep and reapply the stat lock device. Place a disc or gel patch and then place an occlusive dressing over the insertion site, covering both the site and the disc. Place a sticker with the type of device, date, time, and initials on the dressing, and then document the procedure in the electronic chart. Every 12 hours, the midline catheter site should be assessed for patency, redness, irritation, and/or discomfort to the patient. Flushing and assessment for blood return should be performed and documented. Removal should be performed when therapy is completed unless otherwise indicated. Midline catheters should be removed if swelling, redness, irritation, or complaint of patient discomfort occurs. Before you attempt to remove the line, you need to know how long the line is. At our facility, this information can be found under the Mini Assessment Midline Insertion section in ClinDoc. You should gently remove the dressing and the stat lock device from the site using clean technique. Be sure to gently remove the catheter and observe that the catheter is intact. Use manual pressure to assure hemostasis has been obtained. Place a gauze dressing to the site and then document the procedure in the electronic chart. If the line is clotted with blood due to improper maintenance, you can administer 2 milligrams of CATHFLO IV push to the midline in an effort to dissolve blood in the line. Do not forward flush with saline. Only let the CATHFLO dwell in the line, then try to aspirate it. If unable to aspirate with a 3 milliliter syringe, have the line removed or contact the vascular access team. In terms of monitoring, the vascular access team has and will be recording all relevant line placement data. In regards to midlines, we are recording how many attempts, successful placements, failed placements, and how many each member of the team is doing per month. Additionally, we are now recording improper orders leading to delays in treatment, improper callouts, and traditional IV starts that are requested by staff. If you request an IV be started by the vascular access team, they will inquire into how many times you have attempted the line, if a midline may be warranted, and the status of the patient. If they place this traditional IV for you and have determined that you have not made an effort to place a line despite saying otherwise, they have been instructed to report your name to your manager and to float time to your department. The purpose of this video was to provide an overview on identifying, maintaining, implementing, and monitoring of midlines. This was done by reviewing the current research, Infusion Nurse Society guidelines, current hospital policy, and the midline itself. Thank you for watching. I wish you the best of luck in all your ventures and endeavors in the future. If you have any comments, concerns, complaints, or compliments, please respond below. If you want to see more content like this, please like the video should you deem it worthy, and consider subscribing to the channel. Your support steers the content we develop. Again, thank you for your time and have a great day.